At this time, I would like to ask Susan Towler to please take the stage. Thank you.
Thank you, Velma. We're all wondering where that voice is coming from. I see you in the corner. Good morning. How is everybody this morning? Great. Welcome to the 11th Annual Sapphire Symposium and Awards. As Velma said, I'm Susan Towler. I'm really honored and so proud to welcome you again to our symposium. Who did yoga? I know Linda Moffa did yoga because I saw her this morning. Thank you to Monica Stone, who conducted our yoga classes each morning, and I know several of you took advantage of that. So I'm glad you're rested, and namaste. Did you enjoy yesterday with a round of applause? Great. We started off with Dr. Joe Betancourt talking about disparities, and Dr. James this morning will continue on that theme. We had great small talks yesterday afternoon, and then how many went to the Guidewell Innovation Center? Great. Did you enjoy that? Excellent. If you have a minute, if you'd like, is there any, I know we're going to do feedback and we're going to have an evaluation form, but if there's anything you all would like to share now, like an aha moment from yesterday or something you're curious about, or you have any other question, if you want to, I'd like to give you a minute just to come up to the microphone. If you have any thoughts about yesterday, anything you learned, something you're going to do, something you want to know? It's your chance, anytime. Feedback. Okay, last chance. The Innovation Center, when we went last night, they talked about an event that's happening in August, around August 25th, called Greater Than Cancer. If you're interested in that, please visit the Guidewell Innovation website and find out more about that. It's going to be a great event bringing together the best minds around cancer and cancer survivorship. And so we really encourage you, if you're interested in that, to take a look at that event that's happening at the Guidewell Innovation Center in August. I also really want to thank, again, Velma Montero-Tribble and Susan Wilds and our planning committee. Can everybody clap for them? It's been wonderful. I've always had a goal of having our Sapphire event be over 400, and so we're really pleased that we are over 400 people attending various parts of this event over the last 2 days, so congratulations. I'm really proud of that. Thank you. Have you used the app, and do you like the app? Great, wonderful. And please visit our exhibitors. We have 15 exhibitors outside, and they've providing wonderful services and some tools and tips. So I encourage you to please visit them. They'll be here today, round up to lunch. And we are having our Sapphire Awards luncheon today at 12:30, right back here in this room. At this time, I'd like to introduce Mr. Harris Rosen. Those of you in Orlando know Mr. Rosen and what an incredible businessman he is, but he's also a wonderful philanthropist. He is the president and chief operating officer of Rosen Hotels and Resorts. I'd like for him to come up and give us some brief remarks this morning. Mr. Rosen.
Thank you. Be careful. The key word in that sentence was brief, yes. So, are you guys enjoying this property? So we have 7 little hotels here in Orlando, and they're all my children. So the Rosen Plaza is one of my children. And the Rosen Plaza is very sad because you're all here enjoying yourselves. We have 7 rabbis running around our new kosher kitchen at Rosen Plaza right now, driving us mashugana. So here we are. About 25 years ago, I was sitting at my desk and had what I would call an epiphany of sorts. My family came from Eastern Europe, Ukraine, Austria-Hungary, settled on the Lower East Side of Manhattan, a neighborhood commonly referred to as Hell's Kitchen, and it was where I was born and raised. Sitting at my desk, building our 5th hotel, planning our 6th, and dreaming about our 7th, I just had to say, thank you, God. The epiphany was a voice that said, it's now time for you to offer a helping hand to others because you've been blessed beyond anything you've ever imagined. So at that moment, I knew that for the rest of my life, giving, providing assistance, helping others was going to be an important part of my life. And so we created the Rosen Foundation. Education was always something terribly important. My mom and dad insisted that my brother and myself focus laser-like on school. Of course, I was the first to go to college. Somehow, Cornell University made a terrible mistake, got me confused with somebody else, and accepted me. And that's where I went for 4 years. Graduated right into the Army, 3.5 years overseas, and then I started my career working for other people and not really enjoying it as much as I should have, perhaps. The final straw was when I was asked to leave Disney, and that is when I made up my mind that I would, whatever it was, I would do my own thing. And so we started with a little motel where my office still is. We bought it for $20,000 cash and assumed a $2 million mortgage. And so, yes, we had to create a foundation to help others. So the Rosen Foundation was created. And the first thing we did was to adopt an underserved community here in Central Florida called Tangelo Park, a community that was struggling with crime and very low graduation rates from high school. With the help of 2 educators, we created a very simple program. Every 2, 3, and 4-year-old, free preschool in the neighborhood. Work with those children. Work with their parents, mentor them, help them, guide them. From a 45 to 50% graduation rate from high school, we now, over the past 23 years, have achieved 100% graduation rate from high school. But we had to promise something. So we said, every youngster from the neighborhood who was accepted to trade school, community college, or four-year public college in Florida would get everything paid for. Room, board, tuition, books, everything. So in a neighborhood that was graduating about 45–50% from high school, we now have a 77% graduation rate from four-year college. The neighborhood has transformed itself. Crime in the neighborhood is down almost 70%. The sheriff mentioned to me not too long ago that we now consider Tangelo Park to be an oasis in Central Florida. Less crime there than in some of the most affluent gated communities. He said, we're so proud of what Tangelo Park has become. Sadly, in the 23 years we've been doing the program, even though we've spoken to some very wealthy individuals, some of the largest foundations in America, the program hasn't been replicated. So about a year ago, we decided to expand the program, and we've adopted another community here in Central Florida called the Paramore neighborhood. It's 5 times the size of Tangelo Park. And because they don't have any single-family homes, we've created a new template which we believe will be replicated, we hope and pray, throughout America. We call it PS8, preschool through 8th grade. No busing, everyone in the neighborhood walks to school. The 2-, 3-, and 4-year-olds have their own little section. Kindergarten, elementary school, and middle school, and then everyone goes to Jones High School. We're already prepared to provide full scholarships to youngsters who are graduating from Jones this year. And then we start, when the school is completed, with our 2-, and 3-, and 4-year program. It is our hope and our prayer that we will see the same results in Paramore as we've seen in Tangelo Park. Our foundation also does work in Haiti because 1/3 of our associates are from Haiti. We're building a school right near Port-au-Prince right now. Our partners are Food for the Poor. You might have heard of the Rosen College of Hospitality Management. We donated land and helped build the school. It's now referred to as the Rosen College of Hospitality Management. We've grown from 75 students to 3,600, the fastest growing college in America. 4 of my kids, 3 have graduated. Shayna has another month and a half, and she will have graduated. That must be for the boys, because I'm asked on occasion, how do the 3 boys compare to Shayna academically? And I say, well, it's easy. You take the grade point average of the 3 boys, add it up, and Shayna's is a little bit higher. She's graduating in 3 years. It took the boys years, but they're finally done. So we've got the Rosen College, we've got Haiti, we've got Paramore, we've got Tangelo Park. We have a scholarship also at University of Central Florida, a $5 million endowment. We gave 160 scholarships just recently. So yes, we are in the hospitality business, but because I've been blessed so much, we've created the foundation, and the foundation does so much wonderful work. And I'm so proud of the fact that our little company kind of has a reputation now of being one that does give back, that does care a great deal about our community. And so, I just want to wish you all a wonderful conference. You can fall in love with this property, but my colleagues at Rosen Plaza miss you so much. Think about them on occasion. Have a wonderful time, and God bless.
Thank you, Mr. Rosen. What a generous spirit. Really wonderful man and company, and just a great property for us to have our 11th symposium. Now it's my honor and pleasure to introduce Jason Altmire. Jason is the chair of the Florida Blue Foundation Board of Directors. He's also the senior vice president for our public policy and community engagement team at Florida Blue. Jason.
Let's have another round of applause for Susan and Velma and the team that helped put this together. We are now, for the first time in 11 years of doing this program, we're over 400 registered attendees, all-time record. Thank you for that. And the reason that this has grown so much is because of speakers who come in and provide information from a perspective that helps all of us understand what's happening in the philanthropic and nonprofit worlds. And today, for our keynote address for the Symposium and Sapphire Awards, we have Dr. Cara James. And we are so thrilled, Dr. James, because she has been so successful in her role as Director of the Office of Minority Health at the Centers for Medicare and Medicaid Services, CMS, that under her scope, they've tripled the size of the organization, and she has rolled out multiple initiatives that have made a huge difference, not just across the country, but big differences here in Florida. She has initiatives to attain health equity, to reduce health disparities, and to improve minority health. She has rolled out initiatives to improve the quality of Medicare as it relates to minority health. And her Coverage to Care initiative has made a huge difference in Florida and across the country because it helps connect people to care, help consumers understand what their insurance options are, and help connect them to the most appropriate source of care. But I think what I'm most impressed by of all that is she, for the first time, has improved the quality and the quantity of the data that exists as it relates to health disparities. And that has held back the research and the development of policy initiatives because you can't solve the problem unless you fully understand the problem. She's made a huge difference in that. And a lot of the success that we've had in the state of Florida, enrolling more people in the exchanges, a higher level of reducing the rate of uninsured of any state in the country, is due to the work that she's doing in Washington, D.C., helping connect people and understand their options. She's a huge supporter of minority health, but she is so involved in healthcare. She's a member of panels and boards for the National Academy of Sciences, the Institute of Medicine. She's widely published across the scope of healthcare, especially as it relates to health disparities. And as if all of that wasn't enough, her academic credentials are impeccable. She has a PhD from Harvard in health policy, and she also got her undergrad in psychology from Harvard. And there's more I could tell you, but I will refer you to the Sapphire app where you can find Dr. James' full biography. But without further delay, welcome Dr. Cara James.
Good morning to all of you. Feel a little bit like after that I should just sit down and just say thank you. I'm really excited to be here and really excited at the time that we are in right now as we think about health equity, improving our country's health overall and our healthcare quality. And it's an exciting time because so many across the country are really focusing on what we can do to improve health. And if you recall, years ago when the Institute of Medicine had their reports on crossing the quality chasm, there were 6 principles of what a healthcare system needed to do to meet the needs of a community. And number 6 was provide equitable care. And I think often we sort of forget that when we're moving forward. But if you think about a chain is only as strong as its weakest link, if we don't help others to achieve health equity, our overall healthcare system really will not achieve the potential that it can. And so I'm excited to talk about some of the things that we're doing, but also to make an ask that you continue your efforts, and just hearing of the things that you're engaging in, let us know how we can help support you in your work, because it really does take all of us working at all sorts of levels to achieve health equity. So I'm also hoping that after I finish, and I'm watching the clock up here, that we'll have a little bit of time for discussion, because I do want to hear from you about some of the questions, some of the concerns, some of the needs that you have. This is always a great opportunity for me. I love traveling and hearing from the people who we're trying to help, because you can sit in the offices and could say, the problem is we need to do X, Y, and Z. But I always find when you come out and talk to people, you may find out that actually that's not the problem. This is the problem, and this is what we need. And so I'm hoping we will have some time to do that. So we are one of a number of offices of minority health that have been established as a result of the Affordable Care Act. You may be familiar with the HHS Office of Minority Health, which is celebrating its 30th anniversary this year. It was developed after the Heckler report that came out in 1985. ARC had an office of priority populations that was codified in about 2000 with some minority legislation that also established the unequal treatment report, as well as our National Healthcare Disparities report. And the National Center for Minority Health and Health Disparities at NIH was elevated through the ACA to an institute. HRSA had an office, as did CDC. So FDA, us, and SAMHSA are kind of the new kids on the block. And as we think about what we're doing within our office, we really see that our mission is to ensure that the voices and the needs of the populations we represent, which, as you can see, include racial and ethnic minorities, sexual and gender minorities, and people with disabilities, are present as the agency is developing, implementing, and evaluating its programs and policies. So we're not waiting until our colleagues have decided what we should do within Medicare or what we should do in the marketplace or Medicaid, and then communicating that to our communities, but we're really trying to be at many of those tables thinking about what are some of those challenges that or implications that this particular policy could have if enacted this way on the communities that we focus on. We also recently, some of you may have heard that our acting administrator announced a new CMS Rural Health Council. I am one of the co-chairs of that, along with our Seattle regional administrator, and so we have added a focus on rural populations to our portfolio as well, and thinking about the transformation that we can have within the economics, the quality of care, and within rural communities. And as you can see, we're working towards a vision where all of our CMS beneficiaries have achieved their highest level of health. It means we have a lot of work to do, and it's one of the things that really excited me when I took this position 4 years ago is it's not what to do, it's where to start. CMS is really large, and you think about the impact that it has on people's health, providers, hospitals, health systems, and other communities, and there's a lot of opportunity there. It's also one of the things that, there's a lot moving really quickly and trying to figure out where are the places we can have the greatest impact. So one of the things that we're trying to do across the agency is to build what I call sort of health equity ambassadors. I can't be at every table, and neither can the staff that works with us do that, but how do we get our coworkers thinking about these and asking some of those questions so that we don't have to be at every single table? We think that we can achieve health equity through this path, and this is simply our USA framework. And as you can see, the first step on that path is increasing understanding and awareness of health disparities and their causes. The second is developing and disseminating solutions. And the third step is implementing sustainable actions through both ourselves and the stakeholders that we work with. And we think that through these actions and along this path, we can achieve health equity. It is infusing all of the work that we do, both in our office and with our colleagues across our agency and the department. And when we think about, again, that input, where can we have that impact? It's at every single level. So not just at the policy level, but working in our communities, drilling down to the organizational, the interpersonal, and ultimately to the beneficiaries and consumers we serve. So we think about how do we do this at every single level. And it's for this that, again, we need those partnerships because we have a lot of work to do and we need so many people engaged in it. So some of the things that we have underway, as you heard earlier in my introduction, is including an effort to strengthen our CMS data and systems so that we can do a better job of understanding our disparities and our causes, so that we can also help you and others who are engaged in this work understand where you may have disparities. Not everyone has some of the analytic capabilities that we do, so we provide tools. One of them I will talk about in a little bit, but we also have been releasing some data. Just this week, we have released our Medicare Advantage contract level data for HEDIS and CAHPS, stratified by race and ethnicity. This is the first time CMS has ever done that. And we have, at the contract level, to the ability that we can report opportunities for individuals and organizations to see where they may have challenges to try and identify how they can move forward. As we said, these data don't tell us why the disparities exist, but they do tell us where we have challenges and hopefully can galvanize us to do a little bit more. We've also been implementing the Section 4302 of the Affordable Care Act standards that were created around expanded race and ethnicity categories, because although we have bigger buckets, we do know that there are groups that comprise those who are any population, quite honestly, Asian American, Hispanic, African American, white even, very heterogeneous underneath that. And people have different experiences based on their ethnicity and where they're from. We also are working on building a business case for health equity. And this is something that, how do we talk about health equity in a way that increases the resources and the support for the work that we're doing? Oftentimes when we think about minority health, it's not often well-funded or well-staffed. And so what is the business case that we can make to the C-suite and to others about what the importance of health equity is so that we can move forward? And then, as I mentioned, we're also developing some tools and products to share the information that we're learning and building on that. And in November, we announced that we are supporting researchers into our virtual research data center at CMS to allow access to some of the broader data that's available to have researchers using our data to do disparities work and to understand that. And so we're supporting 5 researchers for the next 3 years. To do that, we figure it takes a little bit of time to get comfortable with CMS data and to be able to use it, so wanted to allow enough time for them to work on that. So we talked about with the categories on race and ethnicity, we're also looking at primary language. 60 million individuals in the country speak a language other than English at home, and 25 million of those individuals speak English less than very well. Their experience within the healthcare system, their ability to navigate the system to get the care that they need varies. And if I showed you a map of the top 10 languages in the country compared to the top 10 languages here in Florida or the top 10 languages in another state, you'd see the variability. And so one of the things that we still struggle with is, who are our beneficiaries who have limited English proficiency and who want materials in other languages? And so we're working to improve our collection and analysis of information so that we can better serve our consumers to help improve their health. We're also working on some work to help understand individuals, their sexual orientation and gender identity. And we've done some work on our transgendered claim analysis to identify those individuals, but also cognitively testing questions for some of our older Americans to ask about sexual identity and sexual orientation and gender identity. And then, as was mentioned earlier, we have an initiative from coverage to care and our CMS equity plan. And these are the things that I'm going to spend a bulk of my time talking about today. From Coverage to Care really is that effort, as you can see, to help educate consumers about their coverage and connect them to primary care and preventive services that are right for them. So we like to talk about this. This is the So You Got Coverage, Now What project. And when you think about who the uninsured were as they came into the healthcare system, many of them didn't have a usual source of care. Many of them had been long-term uninsured for more than 2 years. Many of them lower levels of educational attainment, lower levels of income. And the notion that we're going to give them an insurance card and they're going to be able to figure out this complicated healthcare system to get the care that they need, I think left a lot to be desired. And so we really started to build on what we could do to help support those. We talked to stakeholders across the country to find out what the plans were that they had for what they were going to be doing, as well as what they thought some of the biggest challenges were. And from that, we've developed a number of resources. We just launched about a week and a half ago our newest one, which is 5 ways to make the most of your coverage. And it's really 5 things we hope everyone should be able to do now that they have coverage. Know where to go to get answers. Confirm that they have coverage and make sure that they maintain that by paying their premium. Find a doctor, be able to fill a prescription, and other important activities that are important for their care. We build on existing networks because as we were doing the development for this, we learned that, trusted resources in the community are the best way to share the information. Not only that, they're the ones who are going to be there after we've mailed a packet, come and done a presentation, but the ones who are going to be helping, working with the consumers and engaging with them. And so we've disseminated the resources throughout a variety of networks. Our SHIP counselors who work with our Medicare beneficiaries, faith-based organizations, community health centers, health plans, hospitals, you name it. It's across the social spectrum of people who understand the importance of this and are sharing those resources. And we're really pleased that we've had over 2 million copies ordered from our product ordering warehouse and delivered. We've also translated the materials into 7 languages to ensure that the resources are available for those individuals with limited English proficiency. We chose the languages based on the most frequent calls we had for requests for language access at our Marketplace call center. And we also worked with our Division of Tribal Affairs and their Tribal Technical Advisory Group to develop a version that was unique to our tribal beneficiaries who have unique aspects of the Affordable Care Act. Some of the most popular tools that we have include our example of an insurance card, as well as a table that's available as a one-pager that's an example of some of the differences between primary care and emergency care. As we were developing and testing this, we heard over and over again that people wanted us to help consumers understand some of the financial implications of the cost of the choices that they make around their care. And so you'll see the number 1 line in our table for the emergency care versus primary care is the difference in copay that you can expect to receive if you go to the emergency room for a non-life-threatening illness or injury. We have other prevention resources as we focus on moving forward to help people really think about a use of healthcare that is different from what they've had before. If you think for many people who were uninsured, health insurance was something that can help you when you get sick. But if we're going to really transform our health system and our population health insurance and our coverage really should be something that we think about as a tool to help us stay healthy and not just something where we wait until we get sick to use. So that's one of the reasons we've developed some of those resources. We also learned in our first year of enrollment that everybody picked plans based on the cheapest one. And so for them, a number of them, as we talked to consumers afterwards, we heard they were fearful of using their coverage because they were scared that they were going to get a huge bill. And so again, that's not necessarily helpful in connecting people to coverage. So we developed a resource, an enrollment toolkit for our sisters to use to help consumers think about how to pick a plan that best meets their needs. And so these are the sections that we have in here, as well as another section that focuses on working with some of the special populations or unique populations, such as people with disabilities, our American Indians and Alaska Natives, immigrants and their families, and others. So as we were thinking about our equity plan and why we needed to have one, we thought, one of the things that kept coming back to my mind is the National Healthcare Disparities Report. Each year that comes out since 2003, and that shows that despite the fact that we're making improvements in quality for everyone, all racial and ethnic populations, individuals who are low income, and our gender, we still see that the gap in many of our disparities is not changing. And so we wanted to think about what we specifically at CMS could do to really focus on reducing that gap. We wanted to align with our CMS quality strategy goals. And these you can see are the 6 strategy goals that we have on the outside. And internal there are the 4 foundational principles. And as you can see right now, number 1 at the top is eliminate racial and ethnic disparities. And so we've taken, of course, a broader look at that because of the populations we focus on, but it really is how do we eliminate disparities throughout all of the goals of our work. Again, this shows you what's happening within the National Healthcare Disparities Report. This is the latest one, and it shows that 85% of the disparities between blacks and whites, and 86 for American Indians, 79 for Asians, are largely remaining the same over time. So we needed to be intentional about what can we do to drive down those gaps, because a rising tide lifts all boats. But if you're on different sides of a canal, at the end of the tide, you're still at different levels. And so what can we do to really focus on reducing that gap? We had listening sessions throughout the country. We had 5 of them in DC, Boston, Dallas, Chicago, and Seattle. And these are the themes that came out of those listening sessions. Number 1, as you can see, is collect data. Align policy and payment. Cultural competency. When we had these listening sessions, we included experts in not just the populations that we focus on, but specific CMS programs, because as I told our team, I wanted to have a list of things that are specific to CMS and not general to the Department of Health and Human Services, because CMS is where we focus our efforts. So the 6 priorities that came out of that, number 1, expand the collection and analysis of standardized data. And I've talked a little bit about some of the things that we have underway there earlier. Number 2 is to evaluate disparities impacts and integrate equity solutions across CMS programs. One of the ways in which we've been really pleased is for those of you who may be familiar with the recently announced Accountable Health Communities model, you'll see that in there is a disparities impact statement or a health resource equity statement, where we're asking applicants to not only look at the disparities that are present in the population that they're planning to serve and how that compares with the community, but to put in place a process to monitor those disparities as the model is being implemented and to provide continuous quality improvement should they see that those disparities are worsening. And we're excited because this is the first CMS model to include that. And not only is it included, but it is a part of the scoring. It's a small part of the scoring, but it's a start. And we're hoping that we can work with our colleagues across the agency to do more of that and to think about what we can do to really sort of embed health equity into our programs. But we're also looking at what is the impact of some of our policies. So to provide an example, as we're thinking about the Rural Health Council and some of the work on rural communities and rural hospitals, there are a lot of programs that have payment incentives associated with them. And we do impact analyses to see how does it affect DSH hospitals, how does it affect rural hospitals and those sorts. But rarely have we actually done a cumulative look at how do all of the programs stack up so that we see what is the cumulative burden of a particular set of programs on a given set of hospitals. And so that's something we're beginning to look at to see what the disproportionate impact could be and are there ways that we can mitigate it. And it's interesting because the impacts are not always the same, where it's always really bad for rural hospitals and not quite as bad for DSH hospitals, but there's a lot of variability. And I think that that also speaks to another question to try and drill down and figure out what's going on there. But it's somewhere where we're starting to look at what is the impact, and as we're moving forward and moving more towards a system of paying for quality. One of the other things that keeps me up at nights is we think about as we're moving towards a transformative healthcare system and delivery system reform, doing much more innovation in healthcare. For a lot of our models, by statute in some cases, there's a barrier to participation. You have to have so many patients. You have to have an electronic health record. You have to be doing other things. And for some of our providers who may be treating vulnerable populations, they may not be able to meet that threshold. And so what does that mean is we're supporting innovation in certain areas, but maybe not in others. Are we inadvertently increasing disparities? And if so, what can we do to make sure that we're supporting providers to meet that threshold so that they too can participate? It's one of the reasons we're excited about the Transforming Clinical Practice Initiative, because that really is trying to get those providers to a level where they can participate in these programs as we're moving forward. In one of the other things that I'm sure you probably are aware of, with the new Medicare Access and Chip Reauthorization Act, or MACRA, there's a new program that's coming forward in terms of our merit-based incentive payment system, MIPS, as well as our alternative payment models. And so when we had the request for information this past November, one of the things that we were excited to work with our colleagues on is to put in there a potential focus on health equity, to solicit comments on how should we embed health equity and a focus of health equity into the program. Should it be a subcategory of achieving health equity in the clinical practice improvement activities? Should we have developed performance standards around this? And so we'll be continuing to work to think about that and to share as we're moving forward a focus. But it's a very exciting opportunity where this program is being created from the beginning, and it gives us an opportunity to really think about how do we want to embed a focus on health equity, again, to make sure that as we're moving forward, we are working to improve the health of everyone. Our third priority is really about developing and disseminating promising solutions and approaches. And this, as you heard yesterday from Dr. Betancourt, he may have talked about one of the things that he has worked with us on in the Massachusetts Disparities Solution Center over at MGH, and that is a guide to reducing disparities in readmissions. And so this is one of the tools that we recently released, focusing on what can we do to reduce those disparities. A lot of people are engaged in readmissions and trying to improve that across the board, and so there's some tactics there to help people. We also have recently released our Mapping Medicare Disparities tool, and this is one of those tools for analytics support to help those who may not be able to do this sort of analysis, but it allows you to look at about 18 category conditions, costs, mortality, hospitalizations, readmissions, PQIs, of down to the county level by race, by ethnicity, by gender, as well as for dual and individuals and our beneficiaries who are under 65, to look at where you have some of those challenges, and you can compare two racial and ethnic populations at the county level and see how they compare to the state and national averages. Our fourth priority is increasing the ability of the healthcare workforce to meet the needs of vulnerable populations. And as you can see, this focuses on making sure that we have a culturally competent workforce, but also thinking about multidisciplinary teams and building that business case and for community health workers, as well as enhancing the utilization and implementation of the national class standards. Our fifth priority, not surprising based on what I said earlier, is improving communication and language access for individuals with limited English proficiency and persons with disabilities. And the persons with disabilities is important because we often think about language access from those who are non-English speakers or have limited English proficiency. But there are also communication challenges for people with disabilities that are sometimes unmet. And so we wanted to make sure that we added that to our focus and to think about what are some of those best practices and how do we share that information. And our sixth priority was driven exclusively almost from our stakeholders. But this was something that we heard over and over again about something that we really need to do of how do we increase the physical accessibility of healthcare facilities. This goes beyond making sure that the doors are wide enough or that the ramps are available, but we also think about, clinical environments. Are the tables accessible, or does someone have to have an exam in their wheelchair? These are some of the things that we're working on. We held a listening session with experts in this field about 2 months ago and are taking their feedback and building more of our portfolio. So those are our 6 priorities. We will be doing this for the next 4 years. We have activities underway in each of these priorities, and we'll be building more. This is just some of the things that our office is engaged in, but we are continuing to work to spread across the agency and focus on health equity. We are extremely excited because we have leadership who is committed to this issue. Reducing health disparities and achieving health equity is a CMS priority this year, and our acting administrator, Andy Slavitt, has talked about this in many of his presentations at our National Quality Forum and is a strong supporter. And I know that that means some of you are sitting there saying, yes, but he's leaving next year no matter who's sort of in charge. And as we think about how do we embed this even further, making sure that we have a strong foundation for the work that we're doing. Although the political leadership of the agency will change, the majority of us are career employees, and we will still be here regardless of who's in office come January of next year. I think that the work that we have done and the value that we've added just in the short time that we've been in existence has more of our colleagues who are coming to us and asking for our support and our help in the work that we're doing, and I think that speaks to the strong foundation that we're building and the continuation of the work that will happen. I think one of the other things is when we go back to thinking about disparities, it's never really well funded and well staffed, so we've always been able to do a lot on a little bit, and we'll continue to do so regardless of what happens with the environment that we have moving forward. But I think one of the other things that's incredibly important is strengthening our partnerships and engaging at every level. And we're excited that large organizations such as the American Hospital Association, the AAMC, the Joint Commission, as well as the National Quality Forum, have really made strong inroads and a strong commitment towards health equity. I think that will keep up the pressure in many other places, and why I'm excited about the time that we are in right now. Minnesota recently passed legislation about the inclusion of health equity and developing a focus of how do you do quality measures around this. You also see Trinity Health Systems just announced their health communities that they're really focusing on. RWJ continues to be a very strong supporter. Others, such as the Institute for Healthcare Improvement, and as I mentioned, the National Healthcare Quality Forum, who recently stood up their Disparities Standing Committee to look at quality measures across the board and what we can do. So it really is, to me, an exciting time where a lot of people are working on this. I think that we are seeing a little bit of some of those stars aligning where a lot of things can happen, and we're hoping to really drive towards significant impact. But again, I think it's going to take all of us to get there. As we're also looking ahead in the terms of the implementation of our work, we are going to be doing an evaluation. This wasn't a box checking exercise. Check, we did an equity plan. But ultimately, does it make a difference? And so we're looking at each of the priorities that we have individually and collectively to see what the impact is on our equity goals. So as I just wrap up here and hopefully have a little bit of time for questions, I think we do, the journey of 1,000 miles begins with a single step. It's how I think about our office. It's also how I think about the work that we have from coverage to care and the millions of individuals who've gotten coverage, but also from our equity plan and our perspective going forward. We've taken a first but significant step, but it really is going to take partnership and collaboration at every level of our society to achieve our ultimate goal of health equity, and I do know that working together, we can get there. Thank you.
We have microphones right here, so any questions for Dr. James? We have time for a few questions.
Thank you, Dr. James. I'm Jack Levine. I'm a family policy advocate based here in Florida. I'm very interested in the partnerships that are developing in Florida with our Commissioner of Agriculture, statewide office holder, his name is Adam Putnam, working on nutritional access, especially at the community level, at the school level, and wherever our children and families gather. I'd like to know if there are any similar cross-departmental partnerships happening with Federal Department of Agriculture, FDA, and other federal agencies so that we can kind of turn around some of our negative nutritional outcomes and move more forthrightly towards prevention.
Mm-hmm. And I think, so as you know, this has been a very important platform for which the First Lady's been interested in making sure we eliminate food deserts. One of the areas in which there is collaboration is the Federal Interagency Health Equity team, and that includes representatives from across all of the departments of the government who are working together to achieve health equity. So nutrition and working with CDC and some of the other programs is very much part of that. I think I would have to do a little bit more looking to see what specific programs. I know that sort of we aren't necessarily involved in those programs directly, but there are a lot of collaborations about how do we ensure that some of our food assistance programs, our farmers markets are able to accept those supplemental assistance programs.
Hey, Dr. James, Tom Giles with Florida Blue. Thank you for coming down today. I want to give you the opportunity, you covered a lot of material. Maybe talk a little bit about the big news this week. Yesterday, somebody asked a question about the stratification of some of the data, and the speaker said we don't have it yet, and you, through CMS, came out this week with stratification of data in the Medicare Advantage program. Maybe you can talk a little bit about that. I've read it briefly. Talk about those findings and maybe what you see as the next steps or where we can go from here. I just want to applaud you for having that data released this week, so thank you.
Thank you. So yes, we did release the data, and there are Excel tables that literally you can go in and see by contract number and the contract plans, the data for HEDIS and CAPS measures stratified by race and ethnicity for each plan. We also provided a summary report at the national level of the findings. We were not able to report on every single measure at the contract and plan level, so there is a total of like 27 HEDIS and CAPS measures in the national report, but when you drill down, it's a smaller subset. The measures that we included are the same measures that are part of the STAR ratings program, although these results are not part of the STAR ratings that happen. And so what we found is what we've seen that's been consistent with the National Healthcare Disparities Report, that in some cases that minority groups are faring worse. In some cases, Asian Americans and Pacific Islanders are doing as well, if not slightly better, than non-Hispanic whites. But typically, for a number of the measures, African Americans and Hispanics are faring worse. What I want to kind of leave people with is that I really encourage you to take a look at the drilled down data, because what that shows is that within particular contracts, we have some contracts who are doing very well at serving some of our minority communities. I think that overall, similar to the National Healthcare Quality Report, the data show that we have improvements that can be made for everyone, regardless of race or ethnicity. And so we're hoping that this is a starting point. We've talked to a couple of the plans about their data in the lead up to the release, and many of them were pleased that we were doing this. They were grateful that we put it out. Some of them had done their own analysis, some of them had not. So I think we're hoping that this will start a conversation, and in some cases where the plans have even more data, that they're able to do a little bit closer of a look to try and understand. But I think if, as a model similar to what the American Hospital Association has with their Equity 1, 2, 3 challenge, we're hoping that people will take a look at their specific data, pick a particular gap that they have, and really try and develop programs to support reducing that gap as we go forward. But this is just a starting point for us with the Medicare Advantage data. We're looking to do more releases around some of the stratified data, both updating as well as looking at potentially other populations. So, thank you.
Hi, Dr. James. Thank you for the important work you are doing. My name is Anastasia Albanese O'Neill. I'm a faculty member at the University of Florida, where I work in diabetes research. I'm also a volunteer at the Florida Action Coalition. And my question is, I would just love to hear your thoughts on the role of nurse practitioners regarding achieving the goal of coverage to care here in the state of Florida.
Thank you for that, and thank you for the work that you're doing. Nurses are critically important. I think that the role of nurses, providers, community health workers, all of our healthcare providers is critically important. When we piloted From Coverage to Care, one of the things that we piloted were provider kind of newsletters, because we knew that it's not a one-sided equation. We can't educate and empower consumers alone to show up and get the care that they need if the door is closed or if the door is not receptive. And so we really tried to work with providers as well. Where we were successful, and I think this is a role where nurses can be particularly helpful, is in those provider organizations and practices where there was was a nurse manager or a social worker or a patient navigator, they had more time to explain some of the concepts around coverage to care. And in those places, we found greater retention, comprehension, and much more engagement of the materials than in those places where that wasn't the case. And so I think from the nurses, that is something we would love to see even more of, to think about some of those basic questions that people have, and how do we explain that to help them navigate through the system. So thank you for your work.
Yes, good morning. Thank you very much for your presentation. My name is Maisha Mitchell. I'm part of an initiative here in Florida called Embrace a Healthy Florida. And part of our coalition has been engaged in providing care and support and education to children and families 0 to 5, K to 12, through college, high school. So we are very interested in continuing our work in our area. And one of the things I've been hearing a lot about is the grandparents as parents programs. And people have asked me a number of times how and where do grandparents fit in your work in terms of disparities. I've heard people come to my office and they say, well, I don't have the type of opportunities that people on Medicaid have. Even though I'm living on a fixed income, I don't have that kind of money. So how and where is that plan amount right now around children and parents and grandparents who are taking care of those children in terms of your work with disparities?
Mm-hmm. I think it's evolving. I think that we're learning more and more and seeing more families in which that is becoming more of a normal situation. And I think part of where that fits in is in when we look at the focus on caregivers and what that means, both from in a way that we can approach that is looking at the caregiver's perspective, both from their health, but also the support and services that they need. I think, again, looking at models that focus on some of those social determinants of what are the situations in which our consumers are living and how do we improve that as a care outcome is one way that we can also do that. But I think the specific, some of this, the statute really is going to restrict us from taking a very specific Medicaid focus because of who is kind of covered through that. We have I think, opportunities potentially in the expansion of looking at that, but I think it's more probably going to come from a caregiver focus where we have more flexibilities.
Good morning. John McFadden, Dean and Professor of the College of Nursing and Health Sciences at Barry University in Miami. Our faculty has committed themselves to really fostering a sense of interdisciplinary collaboration, breaking down some silos as we teach across disciplines so that our graduates will be better practitioners and be able to collaborate in the field. What obstacles have you identified in terms of trying to promote that cross-disciplinary or transdisciplinary communication and collaboration, and do you have any suggested strategies that we can begin to use as we prepare the next generation of practitioners?
Yeah, no, in the government we don't know anything about silos. No, I think that it's critically important. I think one of the things, so you heard where I was trained, and one of the things that I loved about my particular graduate program is it was an interdisciplinary program. So it was a combination of the med school, the School of Public Health, the Faculty of Arts and Sciences, the Business School, and the Kennedy School of Government. So getting that training is critically important, and it's one of the ways in which one of the things that is a mantra that I kind of say when I'm working is that we need to meet people where they are and to use that community-based participatory model. And that's how I approach my colleagues. For some of my colleagues, I can talk about health equity and they get it. For others of my colleagues, I have to talk about the finances. Or for others, I have to talk about the risk associated with things. And so I think that what's helpful in that interdisciplinary training is how do you think about things from the perspective of the others that you're trying to partner with and to collaborate with. I think it's always hard. I felt like in the early parts of my tenure at CMS, I felt like I was chasing buses and catching them at the last stop, because you'd sort of hear about something that's underway and trying to figure out how do you get on board with that. And it takes a bit of work to figure out where's the right intersection point, but we've gotten better because as we've had more conversations with our colleagues, more of them are beginning to come to us. And so one of the tools that we have used is a little bit of just an introduction. So we've had sit-downs where we come and meet with the other groups to talk about these are the things that we're doing, because they all have perceptions about what you're doing and how you approach things that may or may not be accurate. And sometimes just having that first conversation about what you're doing, how you're approaching things, and finding out what some of the things that they care about are, and then thinking about how do you engage in maybe one of the areas that they're most interested in, has been one of the tools that we've used that I think has been pretty successful.
Good morning, and thank you for being here. I'm Anna Karina Mascarenas, the Associate Dean for Research at Nova Southeastern University College of Dental Medicine. We just wrapped up a rather large project on developing competencies and curriculum in dental public health for dentists and hygienists. And actually, we used a curriculum that you developed, which is the cultural competency curriculum for oral health professionals. So I'd just like to thank you for that curriculum.
Thank you. Hopefully it was helpful, and always looking for feedback on that as well. Thank you.
Dr. James, thank you for being here this morning and speaking with us. My name is Victoria Hunter-Gibney. I'm with the University of Florida Family Nutrition Program. But previous to that, I worked with the University of Florida measuring quality of care in individuals with intellectual and developmental disabilities living in long-term care facilities. I was wondering, I know you mentioned looking at accessibility for individuals with physical disabilities. One thing I found in my work is that there aren't a lot of nationally utilized quality measures specific to individuals with intellectual and developmental disabilities who often have complicated mental and physical health care needs. Can you speak to that need for developing more measures in that area?
Yes. So one of the things that we've been doing as part of building out our portfolio of how do we support people with disabilities is, understanding the full spectrum of disabilities is very challenging, but we are partnering with our duals office around their demonstration program that they have of looking at the duals care coordination to do a specific focus on disparities within that. We've also been working with our Center for Medicare and the duals office around some potential quality measures that are looking at how do we do a better job, and also understanding how our providers are meeting the needs of individuals with disabilities. And so the intellectual and developmental disabilities, we have a good connection with our group, both within CMCS and our Center for Medicare and Medicaid and CHIP services, and our duals office, who are very interested in this and are continuing to build out more of a portfolio. So that's more work that's in development now. Those are some of the seeds we're sowing that hopefully will yield much more. But the long-term services and supports is something that we are very much have our eye on. Thank you. Yes.
Good morning, Doctor, and thank you for the work that you do. I'm William Johnson with Telemedicine Centers USA. I have a concern, since we recognize the ACA, and a large part of it was focusing on reforming the healthcare industry, and not so much industry as much as reforming the whole idea of delivery of care. To get to equity care, you're going to really have to change attitudes of how care has been delivered. We know that historically there's been discrimination that resulted in what we see to be a buildup of a systemic historic health disparity. What has been done by CMS to either partner with the underserved community itself? Because what's happening is that the providers and the infrastructure that's created, in effect, really has little incentive to change. And there has to be something done within the community itself to insist upon and to support and sustain change. I noticed that you've got accountable health communities now emerging, because the recognition is that it's not just delivering a Band-Aid or a consultation, but to move from a usual place of care to providing for living healthy, as opposed to just a simple deal with an initial problem. But what can be done by your department that encourages partnering with community entrepreneurs, resource development to sustain the delivery of care, access to care that currently is not being provided? If no one sees an advantage to provide the service to people who have the need, then the community itself, they have to create ways in which they can insist upon or draw upon alternatives to care delivery.
Yeah, so there are a couple of things, and one I would say is this is also evolving. And so the accountable health communities is the first one, but as we have within our Center for Medicare and Medicaid Innovation, a group focused on population health, I think we will see more of that. There also are other models, though, where this is very much part of the process. So the state innovation model is one where that is a collaboration of people from the governor's office on down to the community who are looking at how do they improve care, so engaging with the communities and those that they're working with. We also have one of the other ones that we've done 2 awards of is the Healthcare Innovation Awards. And those are unique community-focused efforts that are what's going on in your specific community that you need to focus on. So Delta Dental, South Dakota was one of the early models that really focused on improving oral health for American Indian, Alaska Native women and their children in that area. Or within California, there was a group that was training more community health workers to focus on providing culturally appropriate services for Asian Americans, Native Hawaiians, and other Pacific Islanders. So I think we have some pockets of it. It is evolving as we go further along. I think it's also as you think about within CMS's structure, what are the levers that we have, and that's something that we are sometimes constrained by, but I think there's more opportunity, and I hope that we will see more of that going forward. Thank you.
Thank you. We'll end it right there. Let's have a round of applause for Dr. James. I will now, we promised you she would be awesome, and she was. I will now turn it over to Susan Towler.
Thank you. Thank you for a great morning. We are going to break right now. Our small talk session starts promptly at 10:20. There are 4 breakouts, small talks this morning, and they repeat. So they'll repeat again at 11:20. 2 of them are held in the 2 rooms directly behind us, behind the exhibitors. 2 of the sessions are upstairs, so you're just simply going to go up the stairs or the escalator, and instead of turning left toward the hotel, you're going to turn right, go up a few more stairs. There is an elevator if you need that. It's in the Wakaya room. There's 2 rooms up there, Wakaiwa. And please visit the exhibitors if you haven't, because you know if you've ever done those booths, you bring all the stuff, you don't want to pack it up and take it home, right? It's just, so take it. Take it to your kids who are going to say, Mom or Dad, what did you bring me back from the conference, right? And don't tell them you went to Orlando, because they'll wonder why you didn't bring them to Disney. So please use your social media if you are on that, on Twitter. The hashtag is Sapphire 2016. Please use our app, and we will see you back here in this room at 12:30 for our awards luncheon. Thank you.